Okay, we were talking about Cullen sign. Yep, we're one over. I did that just in time. GI bleeds. So we have upper GI bleeds. I don't know if this can see that side. Yeah, we can. Okay, upper. This is above the ligament of traits. Causes: peptic ulcer disease, gastritis, esophagitis. Esophagitis. I've never heard that word. Variceal rupture. Okay, so this is the lining around the stomach. Variceal. Mallory-Weiss tear. Esophageal laceration. That is nasty. Yeah, the esophageal tear. Actually, I'm thinking of inferior vena cava tear. Actually, still bad, but not. Yeah, because now all of your bile, which is like your level 2 pH acidic gall acid from your gallbladder, your stomach acid, is literally burning into your other organs and their surrounding sacs, their visceral and peritoneal sacs. So we have hem- hematoemesis. Hematoemesis. So hema, right? Hema meaning blood, and then emesis meaning I don't know if it's deeper than just throw up, but basically your bile, your acid, your stomach, you're throwing up. So there is blood in your stomach and you're throwing it up. It's going to look like not coffee grounds, but blood. Actually, yeah, if you throw up coffee grounds, because it's been in your stomach for a little bit, so the blood started to digest. So that's what will happen. Melena, probable. Hematochezia, possible. Hematochezia is, what is this? Not ataxis is, ataxis is, hemataxis is nose bleeding. Hematochezia is bright blood. Because, hematoemesis is coffee ground emesis, and then hematochezia, I'm not sure what tachezia is, but that's bright blood, so it hasn't been in there for too long. In fact, it's bleeding supra to the stomach. Oh, lower. So we have the below ligament of traits. Causes: diverticulosis. So there's still inflammation happening. Not sure. Colon lesions. So you're gonna have almost like scabs, lesions inside of the colon around it. Rectal lesions, again, lesions, anal fissures, please know, inflammatory bowel disorders, ulcerative colitis, and Crohn's disease. Symptoms: melena is possible, and hematochezia is most likely probable. I can't even look at this. Like I can't even read this. Okay, so liver, left hepatic duct. Left hepatic duct. So hepatic, your liver uses filtering. Your liver is what filters. I'm thinking of drugs because depending on what drugs you take, like if you take too much acetaminophen, too much Tylenol, people might not be aware how dangerous that is. It will literally melt your liver, and you're done after that, like completely done. So your liver is hepatic, uses filtering process to filter and absorb different, not just foods, but chemicals and minerals and compounds into the rest of the body. So that is your left hepatic duct. And then I'm not sure what that says. Right hepatic duct. So it's separated. So I guess the smaller one is the left, and the giant one, all of this is your right hepatic duct. It's a terrible diagram. Common hepatic duct. So now we have 3. Nope, there's several. So this must be different. Okay, so it is the inside lining of the vessels that is within the liver. That's what we're looking at. We're not looking at the whole sac itself. I don't even know what that says. This is your stomach. That's easy. Common bile duct. So, right, there's a duct again, just like a duct with air ducts in the house that use aluminum and whatever else to flow the air through your house. You have ducts to get the bile into the stomach. And this is your cystic duct? I don't know what that says. Common hepatic duct. Pancreatic duct. So now your pancreas, where your isle of Langermans is to produce that glucagon that we talked about, it's coming through here. And also insulin. Pancreas is insulin. It's not duodenum. Duodenum perplua. Okay, well, this is duodenum. I'm not even going to try the rest of that. What is this? Something of Terra. I don't know. GI bleed treatment. So the left lateral recumbent or high semi-Fowler's position is going to protect the airway. So we want to make sure that the blood is not, if they're completely flat, supine, then that means that the blood is going to flow into their trachea, down into the lung, and then we have aspiration, and that is a killer that we don't want. So we want high semi-Fowlers. We want them sitting up to protect the airway. Oxygenation via the non-rebreather mask, IV access, anti-emetic for nausea and vomiting. So we're going to give Zofran for this. What is that called? Odinosterone. We would give, not 125. We just did it last night for the heroin overdose. What do we give homeboy? Actually, we didn't even give it to him. We had another old guy, low BP, 74/46. He drank more whiskey than he should have on top of his pain pills, and then they thought he was having a stroke, but he just had low BP and was throwing up. So we gave him Zofran and odinosterone, and we gave it slow push because I'm pretty sure it'll have, what is that called? A contra side effect. Whenever it does the opposite of what it's supposed to do, because you either gave it too slow or you gave it too fast, such as adenosine. Adenosine, you want to slam it really fast, otherwise it does the opposite. Fluid replacement as needed, because again, they are bleeding, so we want to replace that the blood. We can't replace it with blood. Sometimes, if it gets bad enough, I keep going on rabbit holes. So their BP is going to drop as they bleed. In order to raise their BP, we need to fill that blood vessel, just like a balloon, back up with fluid, which we would give IV fluid. If we kept doing that enough, eventually there's not going to be enough red blood cells to oxygenate and perfuse, and other stuff's going to happen. So at that point, we're going to need to start giving blood bags, which we don't carry that on the ambulance anyway, but just to keep in mind for the sake of the test. Anti-emetic for nausea and vomiting, fluid replacement, yep. Oxygenation, so just like how there's not enough red blood cells to throw the oxygen, we're going to increase the molecules of oxygen to help oxygenate and perfuse the rest of the body's organs, blood vessels, everything else, which is why we're giving oxygen on a non-rebreather mask as well. Mallory-Weiss tear, the upper GI bleed. So because it's upper, it's going to have that more hematochezia, red blood, arterial, oxygenated blood, hematochezia. Laceration of the esophagus caused by excessive retching and vomiting associated with bulimia. Tear does not extend through the entire esophagus. So your stomach has enough lining in it, along with your gallbladder and what is it? The gall duct? Yeah, gall duct, pancreas. Where am I looking? I just saw it. I can't read this. Bile duct. Cystic duct, common hepatic, gallbladder, major duodenum, I lost it. Anyway, your stomach has lining to protect you from that acid that is going to chemically react and break down your food, so that way your body can absorb it through the rest of the gastric system. Gastric system. I'm all over the place. Where are we at? Tear does not extend through the entire esophagus. Boer-Haave syndrome. So you have an upper GI bleed again. Rupture of the esophagus from prolonged retching and vomiting. Tear travels entirely through the esophageal wall. Okay, so this is, you're getting there. This is, you've ripped it. Allows for passage of blood, air, and food out of the esophagus and into the mediastinum. 90% mortality rate in 48 hours if untreated. Yeah, not nearly as bad as a inferior vena cava bleed. Kind of done if that happens. Abdominal and GI, so acute gastroenteritis. Let me make sure that this is getting the whole screen. No, it's not. All right, we'll scoot that over a little bit. So acute gastroenteritis, this is inflammation of the stomach, gastro meaning stomach, enteritis meaning in the middle of, itis meaning inflammation. Inflammation of the stomach and intestines with sudden vomiting and diarrhea. Causes ETOH, ethyl, what does that stand for? Alcoholic. Ethanol, I can't remember. Anyway, alcohol and tobacco users. NSAID use, so normal steroidal anti-inflammatory, non-steroidal anti-inflammatory. Come on, what's the D? I don't know. Use of chemotherapeutic agents such as alkalotic acidic ingestion. Treatment of airway and management and hydration. So chronic gastroenteritis. This is long-term mucosal changes or permanent mucosal damage. Causes, you have microbial H. pylori and fecal or oral routes through the contaminant of food or water. Peptic ulcer, this is the number one cause of GI bleeds. Erosions caused by gastric acid may occur anywhere in the GI tract. The duodenal ulcers occur in proximal portions of the duodenum. Proximal meaning further away. Occurs more in males than in females. Cause, non-steroidal anti-inflammatory, nicotine, ETOH, alcohol, and H. pylori. What is that? H. pylori. Not sure. Causes of vomiting, massive hemorrhage is possible, and treatment of you have antacids and bleeding control. So we're gonna give antacids to counteract the acid, just like Tums. Zollinger-Ellison syndrome. This is acid-secreting tumor that provokes the ulcerations. Chronic ulcers may result in anemia. Ulcerative colitis, known to cause and occur in the rectum and large intestines, bloody diarrhea, stool with mucus, nausea, vomiting, fever, and weight loss. Let's talk about abdominal and GI. So I have Crohn's disease. This can occur where in the GI tract, anywhere in the GI tract. Who and why? Familial link, white females, if you love Starbucks, this might affect you. High stress, Jewish population, what? GI bleeding, weight loss, intermittent abdominal cramping, pain, nausea, vomiting, diarrhea, and fever. It is rapid and onset. Diverticulitis, number one cause of a lower GI bleed. Outpouchings of tissue that push through the intestine wall. Diverticulitis, inflammation of the diverticula due to infection. Signs and symptoms, you're going to have lower left-sided pain. Fever, elevated white blood cells, nausea, vomiting, tenderness on palpitation. So as soon as you palpate it, it's not releasing. Yeah, it's as soon as you touch it. If your appendix is bursting and you touch it and then you don't feel anything, but as you let go, you feel that pain, that means your appendix is about to burst. I forget what that pain's called, like not referred, but delayed pain, something. Irritable bowel, abdominal pain, cramping, increased gas, altered bowel habit, food intolerance, abdominal distension. Bowel obstruction, so we have the blockage of the bowel lumen. Hernias, opening wall, insusception, the telescoping effect. Volvulus, knotting, adhesions. Foreign bodies, gallstones, tumors, adhesions from abdominal surgery, bowel and infarction, and extracurricular activities. Appendicitis, inflammation of vermiform appendix, junction of large and small intestines. Occurs mostly in young adults. We have acute appendicitis in the most common surgical emergency in the field. Rupture leads to peritoneal irritation, also known as sepsis, or leads to sepsis. So this is your appendicitis pain, starts in the periumbilical around the umbilicus and radiates to the right lower left quadrant. If your umbilicus, if your appendix is going to burst, it's going to be here. We have the McBurney's point, 1 to 2 inches between the anterior, being the front, iliac crest and umbilicus. So iliac crest is your pelvis, And then umbilicus, belly button, so 1 to 2 inches, your Bernie's point. Cholecystitis. Inflammation of the gallbladder caused by gallstones, acute attack. You're going to have right upper quadrant pain. So let's go up from the appendix. Now we're having cholecystitis instead of appendicitis. Cholecystitis can occur after a fatty meal. If you have pasta and whatever, you have a fatty meal. Murphy's sign, right coastal tenderness. Right coastal tenderness. Cholecystitis. I butchered that. Cholelithiasis. The actual formation of the gallstones, which causes 90% of cholecystitis cases. Pancreatitis, inflammation of the pancreas. 4 main causes. We have metabolic alcoholism. We have mechanical gallstones. We also have vascular thromboembulus or shock. So thrombo meaning it's blocking, embolus meaning it's something that's floating through your blood vessel, not supposed to be there, such as a what was it? I did the whole video on it. Pulmonary embolism. And infection. So you could have infectious disease, 30 to 40% mortality if you do. Can have decreased blood flow resulting in ischemia. And lesions can erode and hemorrhage. Ischemia, so decreased blood flow. Yeah, so ischemia is just like when you're having ischemia in a heart attack, ischemic reaction. Not reaction. What is it called? Anyway, ischemia. So just like whenever you're bleeding and there's not enough blood getting to your organs and your blood vessels and everything else, that's going to cause ischemia because now the cells are dying since they're not getting oxygen to do what cells do, to reproduce and perform their tasks. Lesions can erode and hemorrhage. So if you get scabs and then they erode and then they break, give way, now they're going to hemorrhage blood. Hepatitis types. We have fecal, oral route, pour, hand washing, ew. Bloodborne pathogens, blood transfusions, needle sharing, dormant use activated by HBV. Hepatic blood virus. No, herpes, no. Something virus. Can't remember HBV. Waterborne, developed after transfusion. And right upper quadrant pain is going to be one of your signs and symptoms, as well as jaundice, nausea, vomiting, malaise, photophobia, pharyngitis, and cough. Let's go through all these. Jaundice, so you'll be yellowed because it is your liver. Your liver is not functioning well. And there's bile that's going to the rest of your skin, your cells, and it's orange. It's like bile when you throw up at the end of being sick and you see that color. It's like that's getting in your cells. Nausea, vomiting, we know what that is. Malaise, so you're feeling very like lazy, you're out of it. Photophobia, so you're afraid of lights. No, you're just sensitive to lights. And pharyngitis, so pharyngeal, you're getting inflammation in your pharynx. Coughing. What else? Immunology. Primary system involved in allergic reaction. So our main goal is destruction or inactivation of pathogens that come into the body. Abnormal cells and foreign molecules such as toxins. Immunity. So we have 2 types. We have cellular immunity and we have the attack of a foreign substance. Specialized cells, immune system. Physically engulf and deactivate. An example of this is phagocytosis. Think of Pac-Man. Why? Humoral immunity, more complicated chemical attack of an invading substance. The antibodies are used to accomplish the attack. So you have immunoglobulins, the IgEs, 5 different types of these, but more familiar with IgE. The allergen attaches to the IgE. Okay, I was talking about these earlier. Basophils, mast cells produce histamines. Histamines are like bombs that explode in the cell. That's why when you have an allergic reaction, poison ivy, bee sting, and you swell up, it's because those histamines are exploding, blowing your cells up. They're just nuking it to get rid of the allergens that's causing the allergic reaction. Histamine releases produces bronchoconstriction, increased intestinal motility, vasodilation, and increased vascular permeability. Vasodilation, yeah. Because we want bronchodilation and we want vasoconstriction, which is why we give epinephrine, because it is a alpha 1 agonist, beta 2 agonist. So it's going to pump the heart stronger, faster, because of automaticity, chronotrophy, dromatrophy as well, and then bronchoconstriction, or no, arterial constriction, because it is an alpha 1 agonist as well as the heart, beta 2 bronchodilation. So because it's from the swelling, your bronchioles are going to close up, and then we want them to open up. So that's what epinephrine's going to make it do. Open up so you can breathe. All that's going to happen at once. Epinephrine is a aggressive stimulant. Anaphylaxis, so sudden onset, 30 to 60 seconds. The quicker the reaction, the more severe. Feeling of impending doom. Laryngeal edema, laryngospasm, complete airway obstruction. So you could have a laryngospasm. Your body is trying to react and keep. What is it when stuff gets in your lung, your trachea? I just said it. Aspiration. Your body's trying to keep aspiration from happening, so it's going to close, and whatever it thinks is going to come in, it's laryngospasming shut. So your airway's shutting. Even though that's going to kill you, it's trying to protect you from other more acute dangers that's happening. Laryngeal edema. So yeah, because there's a laryngeal edema, it's keeping that swelling, that fluid from getting in. Complete airway obstruction. Tachypnea, wheezes, increased diminished lung sounds. So tachypnea, fast breathing, wheezes, high-pitched upper airway whistling, pretty much. Diffuse, rash, hives, raised on the skin. Yep, just like we talked about. Management, so we want to monitor cardiac monitoring, because we're looking at the heart to make sure that that's good. Consider early intubation before we get the swelling of the throat. If we know that's going that route, we want to take it while it's open. So go ahead and intubate. IV with fluids. Oxygen is first line medication. We want to make sure they're getting enough oxygen, because it's closing up, that's going to be limited soon. So we want to pre-oxygenate to make sure they're good, especially before we intubate. Epinephrine, 1 in 1,000. This is one of the cases where we're going to give 1 in 10,000, because they're getting closer to circling the drain. Epinephrine 1 in 1,000 goes in a 0.3 to 0.5 milligram intramuscular every 15 to 20 minutes. So when you have an EpiPen for an adult dosage, that's that 0.3 milligram, I guess maxed out at 0.5 depending on your body weight. And then when you have the PediPen, the pediatric EpiPen, that's going to be half, so 0.15 milligram of epinephrine. And that's 1 in 1,000. Then we have 1 in 10,000 epinephrine, more potent. 1 in 10,000, we're going to give 0.1 milligram IV push. So we're giving it not intramuscular, we're not giving it intramuscular. This is like surgically going in, and we're giving a tiny amount because we're trying to like flick the heart with it. Benadryl, steroids, and albuterol. So yeah, all of these things are going to, what does each one do? Albuterol is going to coat your bronchioles, whatever's at the end. So it's going to coat as long as it can get there, because if it's already closed up, then you're not going to be able to put albuterol in there. But that is going to, I forgot what that does. Shoot, I got to go back and look at that. Steroids, yes, steroids are good for allergic reaction. So is Benadryl, obviously. That's what we give first. As far as our protocol goes, I don't know that for sure. But we give 50 milligrams of Benadryl. I forgot to, if I saw it, I could recognize the general name. Vasopressors, as needed. Vasopressor, so epinephrine is a vasopressor. Vasopressin is a vasopressor. So is norepinephrine. Because we're trying to boost that BP, get that BP up after everything else that we've handled. Anaphylaxis will eventually lead to anaphylactic shock, which is a subset of distributive shock. For all subset, I want to make sure this is still going. Are we still going? Nice. Let's stop there.